Thanks for your patience as we let everyone in from the waiting room. Thanks also for keeping yourself on mute as we get started here. We will let our large group in, and I think we can get started now. This is Libby Sagara. I'm with the eConsult Workgroup and Blue Path Health. If you're new to our group, we meet on a monthly basis to share presentations, best practices, published research on eConsult, and we're glad to have a group that's not just California, but moved to both national and international presence. So glad to see new faces on our call this month. I'll do a quick run through of our agenda. We are featuring some presenters that we've had on our group in the past. We're so happy to have Hannah Burns-Enoch and Michael Barnett join us once again to present their publication, Association of eConsult Implementation with Access to Specialist Care in a Large Urban Safety Net System. We have spent a lot of time recently looking at eConsult in rural settings, looking at transportation, cost savings, and patient satisfaction. And it's great to see a different perspective. I hear what's happening in New York and what's also happening across the country today. So we will zip through our agenda talking about some recent events. We recently had a CME on pain management. We'll share some highlights of that. Share some policy updates, what's happening across the country, and a reminder for our meeting that's taking place on November 3rd. With that, I'm going to introduce our speakers for today. Most of you get our monthly newsletter. If you don't, I'll make sure that you do get it. And we were pleased to see about a month ago, late May, once again, Dr. Barnett and Hannah published this article that they'll be featuring today. We are glad to see eConsult is really taking off in New York. We'd love to hear the impact that we're seeing in terms of safety nets and improvements in access to care. So with that, I'm going to let you introduce yourself, Dr. Barnett and Hannah, and please go ahead and take it away. I think you're going to share your screen.
All right, thank you so much, Libby. Let me share my screen.
Good.
Okay, and everyone can see slideshow, okay? All right, great. Hi, everybody. It's always a pleasure to come back to the eConsult Workgroup and present our work. You guys are very much a target audience for a lot of the work, and I really appreciate the spirited discussion around folks who kind of really get the value of eConsult and its potential for potential delivery reform. I am an assistant professor at the Harvard T.H. Chan School of Public Health, and I'm also a primary care doc at Brigham and Women's Hospital. I'm in the Health Policy and Management Department, and a lot of my research focuses on understanding the healthcare delivery system with a special interest in the interactions between primary and specialty care and the role of primary and specialty care in the health system. So eConsult really has been near and dear to my heart as a novel delivery reform to help PCPs and specialists communicate in new ways that the health system doesn't quite incentivize, as everyone here is familiar with. So I'm excited to present this work and have lots of Q&A. I think it's going to be hard for me to monitor the chat, but I guess I'm fine if folks want to ask questions while we're presenting, though I think we'll also have some devoted discussion time after this. We're targeting to talk for only 15, 20 minutes, so we'll hopefully have plenty of time afterwards.
Great.
Great. So for some context, and then of course, Hannah will be presenting at the end of this kind of from an implementation perspective, and I'll let her introduce herself when her section comes up. So for context, New York City Health and Hospitals is the largest safety net health system in the US, with 11 hospitals, over 30 outpatient clinics, 4.5 million outpatient visits annually. And it's a very important source of really all specialty care across all of New York City. And as you might imagine, they also have the highest concentration of Medicaid, self-pay, undocumented patients in the city as well. So really truly is an urban safety net. And there were some motivations that will be familiar to many in this group to consider eConsult in health and hospitals, or H&H. A pilot data collection in 2016 showed that there were very long wait times and large variation across the system, which I think was consistent with everyone's anecdotal experience, but it really was cemented by collecting more systematic data on this. And it was decided to give eConsult a try, given the prior evidence that it could really reduce wait times and be kind of a win-win scenario in safety net health systems. And given the success of that eConsult pilot, H&H rolled it out in 2020 to be a requirement for every referral service. And in contrast to some systems, the way that H&H implemented eConsult was that all referrals had to go through an eConsult triage process first, as opposed to being kind of an optional curbside option for PCPs or specialists to ask questions. And sorry, I think sometimes my Zoom connection is kind of wonky, but I'm connected through audio, so folks should still be able to hear me. Is that right?
Yes, you're good.
So here's the adoption timeline of eConsult in the system. We looked at 19 specialty clinics, and I'll talk a little bit more about how we chose that sample. But here you can see in the X's or when the clinic adopted eConsult in this
Dr.
timeline.
Burnett, I need you to share your slides again.
Oh, I'm sorry. Here you can see the timeline where the X's show when clinics adopted eConsult on the timeline from 2016 to 2019. And one thing that I'd like to point out here is that coinciding with eConsult adoption, we find, you can see here that there was a large number of hospitals that transitioned to EHRs not long after eConsult, all at the same time, which was a very exciting, great opportunity for H&H as a health system to transition to Epic, but not as good for a research project when we want to understand the longer term impact of eConsult as a separate intervention from other IT changes. So the reason we did this study was that even though there's quite a bit of research now on eConsults, to my knowledge, this is the first study looking at a really large-scale multi-specialty implementation where we have a very detailed look at scheduling data before and after implementation. So we can really try to track how do things actually change once eConsult goes into effect, and measure, as opposed to just simply seeing how things are going once we've implemented it. I think the reason there isn't a lot of data on this is that for many health systems, implementing eConsult is also the same time that they actually start systematically following a lot of measures like wait time and scheduling. And so that's why, and so I think the availability of this detailed scheduling data is what sets this apart. So what we did is we looked at all referrals in specialty departments in the 7 H&H hospitals where we could have 12 months of data for scheduling outcomes before and after implementation. Unfortunately, the only data we had on patients themselves was just age and gender. You can see kind of the breakdown here. There wasn't really much change, pre and post eConsult, but just to give you a sense. And our overall sample across 19 specialty departments with a year before and after eConsult was over 50,000 referrals. And what we looked at was we looked at outcomes across the whole sample and then also individually within each specialty department. And we looked post eConsult at the proportion of referrals that were resolved without a face-to-face visit. It's a very familiar metric looking at eConsults. But also what we wanted to do was understand the dynamics of how patients were scheduled before and after. So what proportion of patients after eConsult was implemented actually had an appointment successfully scheduled, where the scheduler was able to reach the patient and put something on the calendar among those where a referral was recommended? What was the wait time until the scheduled appointment? And then what proportion of patients actually completed a face-to-face visit within 90 days as sort of a somewhat arbitrary benchmark of, relatively rapid access. The way we did this for the methods wonks in the crowd is something called an interrupted time series analysis, where what we do is many of these specialties implemented eConsult on different dates. But what we do is we kind of define relative time for each of these specialty departments so that month 0 is the month they implemented eConsult. And then we create month -12 to +12 for all of the clinics, which is relative to when they implemented eConsult. And that way we can basically group everybody's data together and just align it according to when they implemented the program. And we compared the outcomes I mentioned across all the specialties with regression models that controlled for the data that we had available. And as I mentioned earlier, one very important wrinkle here is that Epic implementation occurred a few months after eConsult's implementation for over half of our specialty departments, which is a very big change. This disrupts our capacity to see how eConsult made a difference beyond a few months. And we're highlighted in the figures that we'll show you, but it's something to take into consideration when we look at these results. So here are our results. One metric that I know that Hannah and her team were very interested in following was monthly volume. I think there was a concern in the system that once eConsult was implemented, that specialists might actually lose some referral volume over time. In absolute terms, there was a small decrease from 2,200 to 1,900 monthly referrals across these 19 clinics, though in the statistical model, it wasn't a statistically significant effect. And then in terms of eConsults resolved without face-to-face, it turns out that about 13% of the referrals in this time period for this sample were resolved without face-to-face visits. And it dropped a little bit over time. But there was huge variation, as you might expect, across clinics, from almost no eConsults resolved without face-to-face to up to 40%. So here is our one of our main results. So this is the percent of referrals where there was a face-to-face visit recommended and an appointment was successfully scheduled. Did I lose my shared screen again?
Yes.
Can folks hear me?
We can hear you, but we lost your screen.
Okay. So I guess while my internet reconnects, I'm sorry it's so bad today. The percentage of referrals with a scheduled appointment increased from 66% to 82%. And there's a very abrupt jump once eConsult was implemented. And then the percentage of referrals with a scheduled appointment plummeted once we got into our EHR transition period. But we found that 16 of our 19 clinics had increases in scheduling rates. Libby, maybe you can do backup slides, actually, so that we don't have this.
Sure,
Libby, maybe we can do backup slides so we don't have this problem.
Yes, I'll come back. One second here.
Okay, great. Can you go to the prior slide, Libby, just for those who didn't get a glance? So this is the trend in percent of referrals with a scheduled appointment. And one thing I'd like to point out here is just that the baseline in the system was just note that 1/3 of appointments never 1/3 of referrals never had an appointment even scheduled, much less have a patient show up, 66%. And so, we're also starting from a baseline in the system where, we really do need reform in how we get people to see specialists and access them in an appropriate time frame. All right, next slide. Here are the results for wait time. Oddly enough, we see wait time kind of steadily increasing in the year prior to eConsult. And then as soon as it's implemented, it drops actually quite abruptly. It's not a huge change. It's about a 13% decrease from 60 days to 54 days, but 13 of 19 specialties had a decrease in their wait time. Some of them quite dramatic, up to 57 days shorter mean wait time to appointment. Next slide. And here is the metric of the proportion of patients who had a completed visit within 90 days of a referral being placed. And here, unfortunately, we saw no real change. It's about 38% throughout the period. You can see that it starts to inch up actually when eConsult is initiated. It's not a huge change, but it is a noticeable change. But then we go into a big dip once the EHR implementation period rolls around. And there's a big drop as clinics transition through that major transformation. We found that 11 of 19 specialties had improvements in these follow-up visit rates, though they were more modest than the other improvements we saw. Next slide. And this slide has a lot of data on it. Of course, people aren't going to absorb all of it, but I just wanted to give you guys a flavor for kind of the range of variation across the 19 specialty clinics. And what's interesting here is that you can see that the outcomes kind of clustered within facility. So for example, if you look at the Jacobi Hospital in kind of light red, you can see that actually the 3 specialties there had very big increases in the percent of referrals with a scheduled appointment. And then also 2 of the 3 had very big decreases in wait times. North Central Bronx was also a high achiever here, where 2 of the specialties had big increases in scheduled appointments, and all of the specialties had decreases in wait times. Some of the other hospitals, though, didn't really have a particularly dramatic or consistent change, like Lincoln or Bellevue. Next slide. So before I pass it off to Hannah, I just want to give a few of our takeaways from this study, which is that we think that this demonstrates that in 12 months, despite the ups and downs of the period after the eConsult transition, H&H made really meaningful progress on its goals, which is that wait time fell by 8 days on average, and the percentage of scheduled referrals was up by nearly 16%. And when you look at it by specialty, the majority of specialties had important improvements in at least one of these metrics. And these wait times improved despite the fact that actually the proportion of appointments scheduled increased a lot. So that means that they were scheduling more appointments, but they were also able to do it in a more efficient way. It's always going to be unclear how big of an impact eConsult could have had if Epic wasn't implemented during this period. It's possible things actually things might have been even more disrupted had eConsult not gone to an effect. But we'll never know, in part because after this 12-month period in our study, the COVID pandemic came along. So, that obviously changes everything. So we'll never know in this system exactly how things might have gone. And I think that this is, another strong piece of evidence that eConsults are a comprehensive part of improving specialty access and reducing healthcare disparities in safety net populations.
Dr. Burnett, could we pause
Yes.
for a second? And I'm going to ask Ella Schwartz, if you don't mind unmuting yourself. You have a couple of questions here. Maybe you can phrase them better than I can. Go ahead.
Oh, thanks, Michael and team. Great presentation. Really exciting research. I'm kind of curious about the technology in the publication. It says that the eConsults are sent through the EHR, which ended up being Epic. And so are the PCPs all on the same Epic instance, or are there also PCPs in community-based provider organizations? And then how are those referrals or eConsults received?
Why don't I have Hannah take this question, which has a complex answer?
It sure does. So maybe I'll just introduce myself very briefly, as I think also this is a really good time to transition into the implementation part of the presentation. So I'm Hannah Burns-Enoch. I was the director of the eConsult program at Health and Hospitals from 2015 up until about a year ago. And the Health and Hospitals network is a really large one. So to directly answer your question, all of the primary care providers submitting referrals to our eConsult specialties were Health and Hospitals providers, so they were submitting their referrals via Epic. At the time that COVID hit, we had begun conversations with legal, our Epic team, et cetera, to determine if we could expand that out to community providers via Epic Care Link. And we had just about solved the build issues when that got put on hold.
And also, Hannah, my recollection is that prior to the Epic transition, you guys actually had to juggle 2 EHRs, right? QuadraMed and Epic for eConsult. And so eConsult's implementation for some specialties was actually done on a separate EHR system, and the eConsult was just a similar organizational change, but implemented differently.
Right, and that's actually useful context for why this implementation was designed the way it was. When we began, Health and Hospitals was on one medical record, QuadraMed, but had 8 separate, completely distinct instances of QuadraMed. So everything we built had to be built for each of those 8. Which also, and they were completely non-inoperable. So a primary care provider at one hospital could not refer to a different hospital through the medical record. So then in 2016, we began the transition to Epic, and basically had to juggle just a really strange constellation of systems for that time. So the exact answer depends a little bit on which point in time.
And Hannah, how did,
go ahead, Michael.
Oh, I was just going to ask, I'm not sure kind of at what point eConsult was a covered Medicaid benefit or the compensation for eConsults during this evaluation period.
Yeah, it was not. So starting in, again, really our timing on some of these key pieces got very complicated thanks to COVID. So in very, very early 2020, we submitted our first bill for Medicare using, and had, sort of the excitement of figuring out how to appropriately bill just for certain insurers and not for others. So that's another piece that I hope will be being picked up again once things normalize a little bit more. Primary care providers and specialists were not compensated for eConsult time as an additional job duty. And actually, if Libby, I think you're still controlling the screen, do you mind going to the next slide? Great, I think some of these pieces will be answered in the implementation slides. So all of our healthcare providers at health and hospitals are employees. So we negotiated with each CMO, CFO, et cetera, to figure out how to make this work for the specific specialties based on, all of the local details. In some cases, the specialists especially were able to be granted some dedicated time for reviewing the referrals and eConsults. In others, it was handled a little bit differently. It really varied widely.
Do we want to take these other questions, or maybe Hannah, you can go through your other slides first?
Hannah, I don't want to interrupt your flow. Would you like to go ahead and then we can take questions at the end?
Sure, let me do that. Do you mind going back to the first implementation slide? Thank you. So I basically put a kind of a grab bag of implementation related information onto these slides, just thinking of the kind of the key things I would have wanted to know if I was hearing this. So Michael already covered this, but just to reiterate, because I know this is different across implementations, the way we approach this from the start is that eConsult at health and hospitals would be a single workflow. All referrals would be reviewed by a specialist, which had to be an MD, DO, and PPA, and not a resident. We allowed fellows in some cases. All referrals were reviewed and triaged either to get a non-visit eConsult response, which was returned to the ordering provider for review. If the ordering provider was a supervised provider, it also went to their attending, or the specialist could pass it along to the specialty administrator for scheduling, along with an urgency indicator. The other key piece there, I think we've mostly covered this, but the eConsult participation, in no small part because of our very messy EMR landscape, was made by each specialty service at each hospital. Then starting in 2020, we reached full Epic implementation and immediately established a requirement for each hospital to lay out their own plan to reach 100% of kind of, we'll call them eligible specialties. There's a lot of concern within health and hospitals leadership of creating barriers to accessing care and how to balance that with the need to manage referrals, make sure, as we saw from the data, pre-eConsult referrals weren't getting the greatest care and attention. So we kind of struck a balance by establishing a list of quote unquote referral services that excluded certain what they call direct access services like diabetic foot exams and podiatry and women's health and a few others that were excluded from the requirement. And then on the next slide, we already covered this, that we really were able to leave some of the provider reimbursement pieces up to the hospital and the service leadership. And then I think the only other key piece here is the appointment scheduling piece. And I know this is handled in very different ways in different eConsult implementations. But one of the pieces we thought was really important was to have the specialty clinic handle appointment scheduling after referrals had been reviewed by the specialist. And this really allowed us to keep some local control over overbooking, especially. That was a major concern for our specialists, that if they let scheduling out of their own hands, that things could get really messy. And we struck the balance of having the specialty clinic conduct the outbound calls for appointments. And then in 2019 began developing actually a dedicated specialty call center, which was designed to sort of ease the burden on individual clinics, but set up basically a liaison model where, you know, any given chief of service would know exactly who in this call center had overbook access. So if things went sideways, they knew who to talk to, and we had really clear kind of responsibilities and connections back to the actual service for any nuances that they needed handled. And then on the last slide, last piece is just to talk a little bit about how we supported all of this work. Over the years from 2015 to 2020, things grew a little bit, but we basically had a project manager, a data analyst, and a small number of implementation specialists who went in person to do training, who helped a ton with troubleshooting EMR issues, workflow issues, helping establish new standard work, and then work using our very detailed Tableau dashboards to do some kind of quality assurance monitoring, making sure that things were functioning more or less as designed. At various times, that was literally just me. At other times, it was up to 3 or 4 people covering health and hospitals. So while it added up to 5 or 6 people most of the time, that also is covering 11 hospitals and several dozen outpatient clinics. So I think that's it for what I wanted to lay out. I see there are a couple more questions coming in over the chat.
Yes, and Hannah, I'm going to give you this one first because I think it's a great one, and then there's a couple of detailed questions that I'll have people ask themselves. But Stephanie Booth asked, what kind of feedback did physicians give? Or was there high PCP and specialist satisfaction?
Yeah, that's a great question. I would say overall, it was greatly appreciated by both the specialists and the PCPs. And I would also say that when we got negative feedback, it was in one of 2 categories. One was technology related, lots and lots of complaints about things that were more or less due to EMR limitations or improvements to those workflows. So that was hugely helpful. We did semi-routine focus groups and kind of had like a running list of complaints, issues, suggestions that we got over the course of our training, QA, et cetera. So there was a serious effort to do kind of a continuous improvement process on the technology side. And primarily the other concerns that would come in were indicators of other underlying issues, such as perceived excessive gatekeeping on the specialist side. We tended to find out when we dug into these issues that they were pre-existing issues that eConsult made abundantly clear. So we had, certain issues where we would be able to see documented in the medical record that a certain specialist was refusing, a certain type of patient, and be able to take that to leadership and say, it's not an eConsult issue, although that's the system that allowed us to see what was going on here. So that's kind of a long-winded way of saying that while not everybody loved it, it was generally well received. I think the last piece that's pertinent here is that we had 3, almost 4 years of talking about eConsult, people knowing other people who were using it. There's really quite a long period of time in which it became normalized before we began the required push. I think that helped a lot.
Thank you so much, Hannah. That was, I wouldn't say that was long-winded. It was really helpful. I want to point out, Dr. Barnett just copied in an article that we featured a few years ago. I believe this is the LADHS article, correct, Michael?
Yep. Mm-hmm.
Great. I think many of you on this call have seen and heard about this, but it's a great example back to some of the questions that are being asked here. So Hannah, we're going to bring back a few more questions. From Sajid Ahmed, is there a plan to add community PCPs referring into the H&H system to use eConsult?
So when I left Health and Hospitals about a year ago, that plan was on hold due to COVID. We had done, I would say, the majority of the groundwork for adding in community PCPs via Epic CareLink. So while I don't know the timeline or current status, I believe so.
Thanks, Anna. And I'm going to let, or I will ask Darren Anderson. Dr. Anderson, would you like to unmute yourself? You have a couple of questions and I'll let you share them with Hannah.
Yeah, no, thanks. I think one of my main questions was I was surprised at the low percentage of consults or referral requests that didn't need a face-to-face and that got managed with an e-consult. It's lower than the article that Michael Barnett just posted in the chat. It's lower than some of the numbers that we've seen. And I guess I was wondering if you mentioned at the beginning, I think if I heard you right, that there was actually a concern amongst specialists that this intervention might reduce their face-to-face volume of specialty referral visits. So assuming that I heard you right, and that was what you said, to what extent did that concern drive the way the initiative was designed and the decision-making around whether a consult could be managed, with an e-consult versus an e-referral, which it seems like most of these actually were?
Yeah, that was a major concern in the beginning, and that generated quite a number of conversations with leadership at each hospital, trying to better understand what metrics specialties were being evaluated on, were there productivity metrics, et cetera. So some of our approach was to dig into those concerns and find out where they were coming from. And in most cases, they proved to be not entirely founded in reality. And the concern was more with making sure that hospital leadership was really aware of why some of these metrics might look a little different. So we did, to directly answer your question, we did not design the intervention to address that concern. We designed the intervention this way because it seemed like the best way to ensure that every person referred to a service benefited from the specialist's expertise, even if that expertise was simply, this person needs to get in here sooner than our next available appointment. So the terminology e-referral versus e-consult, I think they've been used in a variety of ways. I agree that what we implemented turned out to be more of an e-referral system, but by then the name had stuck. And the e-consult function is a really integral and critical part of this process. One of our longer term plans had been to go back to our e-consult services and start to set what you could call kind of referral expectations or standards around some of these services, especially now that Health and Hospitals is on one EMR and it's possible to create more of a systematic approach to referral management. I think there's a lot of quality improvement work that this has set us up for.
Thanks, Hannah. We have
Hannah, one thing.
Oh, go ahead, Darren.
Just another thing, Hannah, I guess one of the questions, that Darren asked and others is, the number of resolved visits without face-to-face was lower than we've seen in other evaluations. It seemed to me that one aspect of this has also been that culturally e-consult didn't kind of, go over the same in every hospital or every department, which, it's never going to be the case in any big system, but Health and Hospitals is just so huge and there's so much cultural variability that it's possible that some of the low e-consult numbers are just, some people didn't really buy into, using this as more than just an electronic referral system.
Thanks, Michael. We have a couple questions coming in. This is great. Thank you so much for sharing these. I wanted to point out, Dr. Barnett's put a couple of articles up here. Ella Schwartz also shared a great publication from Community Health Center Network and Rubicon in the Bay Area. All of these are housed at econsultworkgroup.com under the research section. So if you're frantically trying to copy links, don't worry about it. We have them. And I'm going to ask Dr. Greg Buchert to go ahead and unmute yourself and ask your question.
Thanks, Libby, and thanks for a great presentation. And what's nice is this really validates a lot of the benefits that we've talked about over the years of eConsult. But something we often don't talk about is the difference in the education that takes place at eConsults that you often don't see in face-to-face visits. Face-to-face visits, you know, specialists talk to the patient, might send a copy of their visit to the PCP, who may or may not even see it. Whereas here, you know, you do see that the education taking place. In slide 9, you mentioned that there was actually a decrease in eConsults. Do you think this could be a reflection of the fact that with the eConsults that took place, there was education and there was less of a need for the consults with the specialist?
I do think so, both anecdotally and in some very preliminary internal analyses. One of the things we saw pre-post was a reduction in repeat referrals. So, you know, I'm mixing up my lunch a little bit. So I think one piece is that folks got eConsults back on one patient saying, you know, in this instance, here's what I would like you to do. Here's the labs I would like you to order. Here's, you know, the considerations you should keep in mind. And therefore, for subsequent patients, they were able to avoid referrals or avoid referrals until that patient was sort of truly, quote unquote, ready for that referral. The other piece that I think is coming in here with the reduction in referral volume is pre-eConsult, we had what our system CEO once referred to as a send and pray approach, where referrals did not land anywhere. There was no tracking. So you would see, you know, for any given patient, you might see a referral to cardiology on every single visit that they had with any provider over several months before they finally got a visit. Once we switched over to the eConsult process, as you saw, while the system certainly wasn't perfect, the odds that referral would be seen and replied to went up pretty significantly. So we were able, so again, anecdotally, providers have told me they felt much more confident that they could send one referral and it would actually do the job.
Thanks, Hannah. I'm one last call for any additional questions. And as we're looking for those last few questions, Dr. Barnett, anything you'd like to say in closing?
Well, I guess maybe just to add one small thing to Hannah's answer about the question about PCP education. I think it's something, you know, we're all very interested in that turns out to be kind of hard to measure from a research perspective. I know there's been an ongoing effort in LA for a while to kind of use PCP feedback as a way to rate the quality of eConsults and the way that PCPs are using them. And I do think that's kind of like that's sort of the next frontier in eConsult research and kind of how we can make this most useful to PCPs as opposed to kind of, you know, just another healthcare referral tool. But, you know, this evaluation was really gratifying. It was a pleasure to collaborate with Hannah and her team. And, you know, please be in touch for any questions or thoughts on your own evaluations or collaborations.
Thank you so much, Dr. Barnett and Hannah. Hannah, do you have any closing words, or are we wrapping up?
I think Michael really covered it. You know, any implementation like this is necessarily going to be messy. It was really thrilling to be able to carve out something that let us really get at some of the key questions about eConsult. I think there's so much more to be done in the future, and I hope any of you looking at your own messy landscape are thinking as well about how you could potentially evaluate your work. And absolutely, please be in touch if there's anything else that would be useful to you to share.
Thank you so much, Hannah and Michael, and it's been great having you involved over the past few years in this work. We always appreciate seeing these articles and data that you gather, so thanks for sharing with us. And as Hannah called out, we'd love to see other program evaluations as they occur. So thanks for sharing. We appreciate your time today. So we wanted to share a couple of other updates of what's happening across the country. And we talk a lot about what's happening in California as we're moving and shaking in eConsult advancement in terms of policy support out in California. And many of you have been following State Bill 365. We were so appreciative to have Dr. Danielle Oren of Redwood Community Health Network, along with Joel Ramirez of Camarena Health Centers, to provide testimony in support of State Bill 365. It's received unanimous support, bipartisan support in California. We're just waiting to see what happens in terms of appropriations, and we'll keep you up to speed with that bill. We are happy to share language around that bill if other states are interested in seeing what's happened in California policy-wise. We were happy to have Mark Carello from Colorado share his presentation on our last month's call. We're pleased to see that the state of Colorado is supporting a statewide e-consult RFP. And Mark has shared with us that that will be released this fall. So when we see that come out, of course, we'll share that with you all. And many of you who are sitting in California are aware that California AB 133 was signed by Governor Newsom yesterday. It's exciting for healthcare overall. Of course, expansion of Medi-Cal coverage for undocumented adults, maintaining Medi-Cal telehealth policy through end of 2022. But of course, we're also excited to see there's a mention of e-consult. We're just always so pleased to see that there's policy recognition for e-consult. And there is a blurb on the inclusion of statewide support for e-consult service to allow PCP and family practice providers to use e-consult to manage behavioral health conditions for patients. So looking at child psych and behavioral health portal. That is early in its planning stages. So we'll be following this and sharing any news that we have with you all on our upcoming work group calls. If anybody is interested in sharing any insight they have, I welcome it. You can speak up now. You're welcome to share any news that you have or discussions that you've had around the bill. Also, there's a question that came in around the presentation by Dr. Oren that was, you may know if you're sitting in California, you can listen in to the hearings on our bills. So if we have anything new happen on State Bill 365, of course, we will welcome you all to listen in. The last opportunity to provide testimony was done by Dr. Oren. So we will keep you abreast of what happens in terms of future hearings. And you do have these slides in your email, so you can read the link to the bill, and we'll keep you updated on what we hear. As I mentioned, you do get our e-consult newsletter, and we scrub what's happening out there in terms of PubMed and other sources to see all this great published data that's coming out around e-consult. Just like Dr. Barnett and Hannah's article, we like to provide you with what we see coming out on a monthly basis. These are a couple of articles that we highlighted in our July news. And we've heard a lot recently about the need for pain management. As you are well aware, it's not just a California problem, but across the country, need for primary care support to provide patients with pain management and medication management. So in response to that, last month, we offered a CME, a continuing medical education opportunity, open to all providers. And so what we want to make sure everybody knows is these e-consult work group CMEs are open to anyone. Obviously, if you are a provider, you are eligible for CME, but these are open to anyone who wants to listen in. So recently we did a CME specifically on pain management, which was well received. We had over 80 attendees on this call. So amazing response in terms of the need for pain management e-consult. Just wanted to share a quick feedback, and it's great to see providers who have such resounding support for e-consult and its promise in supporting their delivery of care. So those who responded with their ability to support their practice in e-consult noted that e-consult for pain management, the skills that they learned on this call would address a practice gap, provided new knowledge and new skills, accentuated or enhanced team-based practices, that they would change their treatment plans, and they really see the improvement or the potential improvement in patient outcomes through e-consult for pain management. So I wanted to open this up I know it's hard with a large number of people on the call, but we really do want to know what is interesting to you all, what might be future topics for CME. We've heard from others, women's health is interesting. We want to know if there are certain specialties that would be of interest, or any best practices within your e-consult delivery that would be interesting to hear or learn about. So please do share those with us. You can send that over to me. I think y'all have my email now, or send them by chat. I think you've heard this a lot lately, but we do want to make sure that you do have this on your calendars. We want to put 2 dates on your calendars. In our last presentation, we noted that our annual meeting would be November 2nd. As many of you have participated in this meeting in the past, we partner up with the Center for Connected Health Policy, California Telehealth Policy Coalition, in doing a 2-day meeting. You can attend one or both days of this meeting. It'll take place November 2nd and 3rd, with the e-consult work group meeting taking place November 3rd. We are hoping that we are in a state to be able to meet in person. Right now, we're a bit on hold, working with spaces to make sure that it's a possibility and that it's safe for everyone to meet in person. So we'll keep you updated on how this is going to happen, whether it be virtual, in person, or both. And we thank our sponsors, especially California Healthcare Foundation, for your support of our work. If you're interested in sponsoring this event, you can reach out to me, and all of the information is available through your email through this link. And lastly, I mentioned that all these great publications that are being sent through chat are on our econsultworkgroup.com website. And you can click through to the resources and research section to see case studies, publications, and a playbook that many of you have contributed to that really shows payer, provider, and clinic strategies for implementation and support. So thank you all for your call, for joining our call today, and for your time. We'll be meeting again at the end of August, and we'll keep you up to speed with the date and time of that meeting. Thanks again for your time today.
Thank you.
Thank you.
Thanks a lot, Libby. Really appreciate it. Thank you.
Great work, Libby. Hopefully catch you soon. Take care.